Hello and welcome to Suicide During COVID, Implications for Emergency Responders. I'm Chris Calkins and I'll be your host. A little bit about my background. I've been in EMS for almost 30 years, the bulk of that as a paramedic. I've spent 15 years as a firefighter before retiring from that. And I've been teaching at the community college level since 1996 in some way, shape, or form. I'm also a suicidologist, and there is such a thing. And I do original research on suicide and related phenomenon, and I've been fortunate enough to be able to publish on that and present my research all over the world. I became a suicidologist on March 5th, 2003, and that's the year that my wife died by suicide. My resolve was further solidified in October of 2008 when my brother also died by suicide. To this point, I've lost 11 colleagues that I've either worked with directly as partners, taught at the college, or have taught with, and we have to stop the hemorrhage. We have to stop the suicides from happening among our own. We must take care of ourselves and our own. So I'm very appreciative that you're joining me today. It speaks volumes that you would even be in attendance for my presentation. Together, I think we can make a big difference, and I truly appreciate that. I generally start presentations with also saying that I have post-traumatic stress, depression, and anxiety. I've been successfully treated for all of those things, and I think it needs to be okay to say that. Unfortunately, I don't think we're to the point where it is, and I have suffered consequences for disclosing these things, and I may again, but that's something I'm willing to do to change the culture, and I hope you'll be a part of that too. Again, thank you for joining me. Suicide is quite frequently a misunderstood topic or phenomenon. It's a lot more prevalent than people think, and it's a very serious public health issue, and it really is comprised of this perfect subjective storm. So everybody experiences the world different. So you and I both go through a divorce. I am devastated, and you're thinking to yourself, woohoo, I get the whole bed to myself. That's an example of the subjectivity of life. And the factors that line up to create this storm or cause a person to die by suicide aren't the same for every person, and they can vary in magnitude and degree. The data for suicide often lags a year to 2 years behind, with 2 years being much more common. So the latest data I have is for 2018. That year, suicide was the 10th leading cause of death. There were over 48,000 suicide deaths that year in the United States, and that number is a false low. It is estimated that that number is anywhere from 10 to 30% higher because of attempts to hide the manner of death or misclassifications. So, for example, an overdose might get classified as an accident when it was in reality a suicide. That year, the crude mortality rate was 14.2 deaths per 100,000 Americans. That is more deaths than car accidents that year, fires, or homicides, just to put the problem in perspective. 2018, there were 1.4 million suicide attempts that we are aware of from looking at hospital data. It's important to note that the United States suicide rate is actually going up on average every year, and the rest of the world, by and large, the rates are decreasing. Now, there's countries with more suicide rates or higher accrued mortality rates than we have, but they're decreasing in their overall rates per capita. So we also put this in the context of the United States is, as we all likely know, the number one country in the world for COVID deaths and cases. And that's not a proud place to be. So these two things combined also make COVID and suicide in the time of COVID especially insidious. Public Speaking 101 tells you to connect with your audience and explain why your topic matters. And I can think of no better way to accomplish that than to show you this slide on some research I've conducted that shows that the rates of suicidal ideation, planning, attempts, and deaths are significantly higher than that of the general population. And many of us in the emergency response field have been affected by the suicide attempt of a peer or the death, with well over a third of us knowing at least one peer who's died by suicide. So responders have a higher rate of suicide as it is. And when we put an extra stressor on top of it, like the pandemic, and for that matter, the social unrest that we've experienced, I am fearful that those rates will go up. So the question of the day seems to be, what effect is COVID having on people's mental health? And what effect is it having on suicide? According to the CDC and a large study done, here's some of the answers to your question. So 31% are experiencing more anxiety, depression symptoms, 26% with trauma-related stressors, 13% that started or have an increased substance use, and then 11% of people in the general population have seriously considered suicide. Now, no one's asked emergency responders these questions, so I don't know if it's higher or not, but I would speculate that it's the same, if not higher. The tentative data for 2019 in the first quarter shows that maybe suicide rates actually went down for the first time in decades in the United States, which is really welcome news. But unfortunately, that was pre-COVID times. So I'm worried that any progress we made in that arena will be negated by the pandemic and social unrest and all the things that we have going on in our country right now. I do know from speaking to an acquaintance of mine who is with a crisis phone call center that there's been a serious spike in calls to the suicide lifelines. And if that's an indication, we need to brace ourselves for the statistics once the newest data's in. One of the leading theories in suicidology, and there is such a thing as suicidology, and we have our own association in the United States, and we have one internationally as well, is that psychological pain is the largest driver of suicide. That pain becomes so unbearable that a person seeks to stop the pain. This is often confused with the wish to die, and that may be true insofar as the person may wish to die to stop the pain, but they don't truly want to die. The root problem is the pain. Who knew that there were actually three types of pain? Those being physical, social, and psychological. MRI studies have shown that pain, social rejection, which is social pain, so isolation or bullying, and psychological pain are all experienced in the same area of the brain, which is the cingulate cortex. You see the diagram here in the upper left showing the area. And of interest to me is also the fact that thirst is experienced in this area, because we know that dehydration can result in higher anxiety levels amongst people. Another leading theory in suicidology is the interpersonal psychological theory of suicidal behavior by Dr. Thomas Joyner. And Joyner's theory posits that three things must be present for someone to, as he would say, overcome an inherently fearsome act and take their life. And these things are a thwarted sense of belongingness, a perceived sense of burdensomeness, and note that that says perceived, it doesn't even have to be actual, and the ability to enact lethal self-harm. Now, if we pull these factors apart, thwarted sense of belongingness and perceived sense of burdensomeness, those could go to both social and psychological pain. So two pieces of the pain puzzle, if you will. The ability to enact lethal self-harm is interesting because it is difficult to harm yourself. I often see this amongst my students when I'm teaching EMT classes and we get to the blood sugar unit. Oftentimes I have the student stick their own finger with the lancet, and because we're a state institution, a lot of times we don't get the automatic ones that you hit the button. We have a lot of the old-fashioned kind, right? You remove the plastic piece and you stick yourself with the exposed needle and put in the sharps. So those are often what the students end up using. If you were to visit the classroom and watch that happening, you would see people putting the needle just against the pad of their finger and kind of gently trying to rock it in, hoping to draw blood. If I don't pay attention, somebody will be trying to pick a scab and get a blood sample that way. And that is just the simple act of pricking one's finger with a lancet, let alone doing something as big as taking your own life. And that kind of illustrates how human beings are really not wired to hurt themselves. The body has an amazing self-preservation instinct. And to overcome that, you need to have this serious ability to enact lethal self-harm. So how do you get that? You can get that through pain, physical. So in other words, if you're used to extreme physical pain, it's a lot easier to experience more. We often reframe pain. Think of the most pain that you have ever had in your life. And then think about what the most pain you ever had in your life before that was. Chances are it wasn't equal. You reframe the pain to the higher level. So my worst pain was my gallbladder surgery, and I would have said that was a 10 on a 10 at the time it happened. And then several years later, my ATV hit a tree. Not me, the ATV, of course. And I broke my arm. I shattered my humerus. And that hurt bad. That was my new 10 on a 10. And my old 10 on a 10 dropped to like a 3, 4, maybe. And that's how we reframe pain. So if you keep exposing yourself to pain over and over, or you have more than one injury, pain is no longer a barrier to some things. And if you experience enough pain, the act of killing yourself, you wouldn't be reticent about the level of pain that you might experience. Because how could it be any worse than this other pain I've experienced? I will say that psychological pain, I do believe, is worse than physical pain. At least at the extremes. It can be worse. And I think of the worst physical pain I've experienced in my life, which was that ATV accident. And I think about the worst psychological pain in my life, which was hands down when my wife died by suicide in 2003. And I will tell you that I would rather run my ATV into that tree 10 more times than experience that level of psychological pain one more time. And that is the power of psychological pain. I've never known anybody who's died of physical pain. Really can't think of anybody. But I can think of a lot of people who have died due to psychological pain. But yet, that's one of the things that we don't treat much or take as serious, especially in the pre-hospital environment. So that's one way somebody can have the ability to enact lethal harm. It can also come from exposure to death and injury of other creatures or humans. I'm just going to hazard a guess that those of you who have been in the emergency response field for some time now, you're not really afraid of death. You've seen it up close and personal lots of times. I'm not saying you want death. I'm saying you're not afraid of it. And that can give you the ability to enact lethal self-harm. So those are important risk factors or elements that if we find ourselves not having a sense of belongingness and we feel like we're a burden, can lead up to a tragedy. You might be thinking to yourself at this point, well, what in the heck is Chris doing telling us about the theories of suicide and the different kinds of pains, and what the heck does that have to do with suicide, suicidality, and COVID times? Bear with me. There's a method to the madness here. That is the stage that I need to set to go through the outcome or the impacts of COVID-19. My next slide here is data from the CDC in a long study where the data was culled from people who died by suicide to identify common issues that were likely contributory to the death. Remember, this is a perfect storm. Just because you experience one of these things doesn't mean you're going to die by suicide. It's that totality of the circumstances, right? You already have depression. You're going through a divorce, a relationship problem, substance use. You are the victim of a crime, a violent crime. All those things can weigh heavy on somebody and create that subjectivity level of pain to increase. Well, what the CDC found was that 42% of people who had died during the study period had some kind of a relationship problem. 28% had a substance abuse issue, 22% physical health problem, 16% job financial problem, and 4% lost their housing. There were other things on the list, but these were the main ones I wanted to pull out for your consideration here in the framework of COVID. So one downside about COVID is it's really isolating us social. And the term social distancing has become all the thing, right? That is actually a really poor word. I would call it physical distancing. Social distancing is really bad. Physical distancing is the necessary that we have to enact, the necessary good, I guess, if you can call it good. We know that social connection reduces impulsivity. We know that it assists in coping with external stressors. And in one study actually found that social connection, and what the wording was, it was an adequate relationship with one other person. One was as important as quitting smoking or losing weight. Now, I'm not saying you can smoke or eat what you want, but I am saying that speaks to the power of social connection. Psychologists have done an experiment where they have somebody put their arm, the research subject, in a bucket of ice water. and they time how long it takes for that person to pull their hand out. And nobody just leaves it in there forever. I suppose unless you're somebody like a magician, like, I don't know, you pick your favorite magician, Chris Angel or somebody, Doug Henning, if he's still around, that kind of a thing. But the average human like us, we would take our arm out. But what the psychologist found was that if another person was there to support that person with their hand in the bucket of ice water, somebody that they knew and cared about, that person could leave their hand in that ice water much longer. So think of psychological pain or social pain that results in psychological pain, sort of like that. Even the biggest introverts in the world, kind of like me, need other people. We just get our batteries recharged a different way. So that's an important thing to keep into context. Another thing I really worry about in this time of COVID is our elderly population in assisted living facilities or even independent living facilities. I have several relatives who are in independent living facilities, and as soon as COVID hit, all kinds of restrictions were put in place. And for example, my father-in-law couldn't remove his car from the garage of the independent living senior living community and bring it back. So once he was out of the garage, they wouldn't let him put his vehicle back in the garage, which basically discouraged him from going out. They also limited the people coming in, and there was a rule that if you left, then you had to self-quarantine for 14 days when you came back. So, essentially, you're darned if you do, darned if you don't, because if you stay there, don't have any visitors, and don't leave, well, you're quarantined permanently, or at least until they lift that restriction. If you go out, then you have to go into quarantine for 14 days afterwards. So I guess, going out and having to quarantine after you come back, at least you get out every 2 weeks or so. So that there's something there. It's interesting to me, and my grandmother is in an independent living facility as well, and a different one. And she is upset that she can't come and go as she pleases. Her observation is that the elderly are being treated like children. So it's always questioning where they are. It's restricting people coming in. A lot of the same stuff that my father-in-law is going through. And she's cognitively like us. She is not diminished at all. She is an independent adult. And I don't think that we would put up with that if we lived in an apartment and we were told we couldn't take our car in and out of the garage or have visitors or things like that. So I think there's also a disparity in how we're treating the elderly. And both of my family members are pretty lonely and wanting visitors and wanting to go out. And so I think that compounds problems as well. So, and we know that the elderly are at high risk of suicide. In fact, it's kind of a false sense of security that they're not at risk. Because if you look at the numbers, suicide's the 10th leading cause of death overall. It's the second or third for the 15 to 24-year-old age behind accidents. And you think, oh, it must be the 15 to 24-year-olds that die by suicide more often than people 65 plus, but that's not the case, because when you're 65 plus, you die of other things, heart attacks, cancers, things of that nature. So it's no longer suicide. It is no longer the 10th leading cause of death. It slides way down, but the numbers are actually higher as far as suicides go than the 15 to 24-year-old age group. So elder suicide is a significant problem in the United States, and we need to address that, and COVID and isolation really concerns me regarding that as well. Since the advent of the COVID pandemic, one doesn't have to look far in newspapers across the country, online news services, whatever, to see report after report of intimate partner violence, domestic violence, if you will. One study uncovered the statistics you see before you, all these increases in intimate partner violence in very different geographical parts of the United States. This is important because we know that people who are the victim of crimes or abuse of some sort are much more likely to develop post-traumatic stress, and that is one of the most highly correlated mental health issues in relation to suicide, along with depression, schizophrenia, substance abuse, and borderline personality disorder, and believe it or not, nicotine addiction, which is maybe a way to mitigate that. And a side note from it, I'm not sure what to quite make of that yet. But intimate partner violence is up, and we're experiencing more of it across the United States. So we know that intimate partner violence often results in increased instances of depression and PTSD, again, to mental health issues that are highly correlated with suicide. We know that 1 in 5 victims threaten or attempt suicide in their lifetime, and we know that there's a link between domestic abuse and the phenomenon of murder-suicide. And what I'll say about murder-suicide is that it is believed that first, a murder-suicide is a suicidal event, and then it is a homicidal or a murder type event, oftentimes, or proportionately more. People often confuse active shooters who don't kill themselves with people who murder other people and then kill themselves. Those are two very psychopathologically different human sets of behavior. So important to keep that in perspective. Suicide prevention can stop murder-suicides. I'd be remiss if I didn't mention children's experiences being exposed to domestic violence. We know that witnessing parental domestic violence results in an increase of an adverse childhood event trauma score. So there's a trauma scoring system. You can search it on the internet. You can take it yourself. It's a series of true-false questions. And we know that higher ACE scores, if you will, are associated with increased risk of suicide. And they can come from sexual abuse, physical abuse, or that witnessing parental domestic violence. Interestingly enough, people who are in the public safety field tend to have higher ACE scores than other people. So one could say that we're actually self-selecting to some degree into our professions. And why is that? I don't know. Your guess is probably as good as mine, but I'd hazard a guess that perhaps it's to make the world a better place than it was for us, or to make a difference, or to change something. That's the best I have right now. We know that approximately 29% of people who die by suicide are positive for alcohol, but I didn't say they were intoxicated. So that's an important distinction. But they are positive for alcohol, and some people say alcohol is the lubricant to suicidality, if you will, because it fosters impulsivity, impairs decision making, increases or decreases rather inhibitions. So all those things can add up to be a problem. But if you're a person like me who looks at statistics two ways, that means that 71% of people who die by suicide are not positive for alcohol. And of course, alcohol is only one substance of abuse. We're still in an opioid crisis. It hasn't been as front and center as the pandemic or our issues with social justice, but it's still there. And I was convinced before the pandemic that a large number of those opioid overdoses were actually suicides masquerading as accidents. They're very hard to untangle, to determine, right? So that's something I was concerned about before the pandemic. But after the pandemic started, there has been reports of a 11.4% increase in fatal overdoses and a 16.5% in non-fatal overdoses, and 35 states across the United States have reported upticks in their numbers of overdoses. So that's really important, and recall that I said that substance use disorders are one of those things highly correlated with increased risk for suicide. Another stressor would be economic in nature, and we know that people who have economic stressors in their lives, that they can be at higher risk for suicide as well. And this has been measured in several countries in several different time periods, that there are upticks in suicide. But suicide, like I said, is complicated, and people don't kill themselves for one reason, and that's because they lost their money. There's lots of people that don't have a lot of money yet don't kill themselves. There's lots of people who have mental illnesses but don't kill themselves. So again, taken in totality of the circumstances, this is another part of that perfect horrible storm. So this graph here is our percent change in employment over certain periods in our history. And of course, the bottom one, or the purple, is our most recent economic downturn. So COVID's a whammy on multiple fronts, including the economy and including our livelihood and jobs, and introduces more stressors. So that is another problem, another one of those pieces of the perfect storm. We've covered many risk factors in this presentation, but to give you a basic list of risk factors in a way that you can remember them, and I know EMS people just love acronyms, so the acronym is PATH-1. And this actually comes from the American Association of Suicidality when they do something called a psychological autopsy. And this is what, and I do those too, this is what we look for retroactively after somebody dies from suicide or it's an equivocal death, so we're not sure if it was a suicide or not, and we want to rule that out in an evidence-based manner. At any rate, ISPATH warm is, and think of these in terms of exacerbation from the COVID environment. So ISPATH warm is ideation, and we know that's increasing in COVID times. Substance use, we've covered that already. Purposelessness, and one can lose their purpose by losing their job, maybe losing family members. Anxiety, self-explanatory. Feeling trapped in a job, a geographic location, a situation, trapped in your house, and not able to interact as you normally would. Hopelessness, will this ever end? Will things change? Withdrawal. So I'm going to stay home, I'm not going to reach out, first out of necessity, but then because I'm not feeling so good, so I want to stay to myself. And then anger, and we've certainly seen a lot of anger over quarantining or people not quarantining, and now for the first time ever I've heard the term mask rage. So people angry because somebody is or is not wearing a mask. And recklessness, so reckless behavior would be another symptom. Usually we say that's engaging in activities that are dangerous or changing habits, such as you used to wear a seatbelt all the time and now you don't. You used to wear a helmet on a motorcycle, now you don't. Those kinds of things. But maybe now it's not wearing a mask, or going out and not worrying about exposures. None of these things is a risk factor, or they're all risk factors, but just because somebody doesn't wear a helmet doesn't mean they're going to die by suicide. But again, you have to take everything in totality. And then the last one is mood swings. So you can see how COVID would exacerbate all of these things here. So that's just kind of a down and dirty list of what to look for in an EMS way to remember. So in the words of Axl Rose, where do we go now? I have a few ideas. I think one of the first things we need to do is be more into psychological pre-plans for pandemics, disaster situations. We do have psychological first aid and some of those programs geared towards psychological impact of disasters. However, in most disasters, interestingly, suicide rates actually go down. And we saw this in 9/11, for example, because people pull together and it's a time of social connection and you get together and you rally and you support one another. Unfortunately, a pandemic doesn't allow that kind of close proximity or support, so that social connection phenomenon is not there, or we predict won't be there, and we'll see what happens with that. But we need to do a better job of psychological pre-plans, especially when it comes to pandemics and things that other disasters that would isolate people. Another thing that we could do would be real-time monitoring of suicide. Right now, there's a 2-year lag before we get results of the suicide rate, that kind of a thing. It would be nice on a state or federal level if we could get a real-time monitoring of the situation. So in other words, a medical examiner finds that someone died by suicide, and they enter it in the computer system, and then the data is immediately sent out. We can do this with COVID, and every day we can tell you how many people died by COVID, but why can't we do that with suicide? And then we can tell if we had a problem related to the disaster with suicide as well. Interestingly, there is a state statute that requires fire chiefs to report any death of a firefighter to the state fire marshal's office. It's a little known statute, and most people I talk to about it don't even know about it. So then the question is, how many people really report suicide, homicide, any kind of death of an active firefighter to the state fire marshal, and how is that information accessible? And I believe the answer is it really just doesn't get reported, and what information is there, I don't know, and I'm not sure about the accessibility. But any real-time reporting of any kind of death of any kind of responder would be highly desirable too, so that we can monitor our own in the context of what's going on. The last thing sounds a little far out, but establish a commissioner of loneliness prevention. And it seems odd at first glance, but the British Prime Minister, former British Prime Minister Theresa May, established a Minister of Loneliness for the United Kingdom because social isolation was becoming such a big problem and taking a toll on the population that that Prime Minister saw fit to establish somebody who was in charge of loneliness prevention initiatives. Why couldn't we do something like that, especially given the high risk of suicide secondary to loneliness? And there is something called being alone together. So loneliness doesn't mean that you're just not in contact with other people. You can be lonely in a sea of people. And there's all kinds of initiatives that could go with that. I could see that as a major public health function. Thank you very much for attending my presentation. The fact that you are here and present for my presentation alone gives me hope that together we can do something about suicide rates. We can mitigate those effects, and we can save not only the lives of the public that we're sworn to protect, but of our own, right? We need to put on our own oxygen masks first before we help the person next to us. That's what the flight attendant told me, and I've internalized that, right? Why would we not take care of ourselves so that we can help others? And if we don't do that, we're really in jeopardy. And we have to change that. We have to change the culture. And we have to make it okay to say that you're experiencing psychological pain, or that you have a mental health concern of some sort and you need treatment, or to get it, or even say, I have these mental health issues and I'm recovered and well and I'm functional. So with that, again, thank you for attending. I hope you got something out of this. At least one thing would be my hope. And I do want to leave you with some important phone numbers. So the National Suicide Prevention Lifelines here. So that's a good thing to have on hand. They can also they can not only help you, but somebody who's in a suicidal crisis. If you don't know what else to do, they can work with you on the line too. There is a national number called Safe Call Now. So that is for responders across the country to call, and the line is answered by peers. So oftentimes in public safety, we want to talk to other people in public safety. And we have a local resource here called MinFire, and they have a 24-hour confidential peer support hotline. You can call that, and you leave a message, and then they get back to you in a timely manner. And this is for firefighters, and they connect you with resources. That not only do they deal with mental health concerns, but also heart issues and cancer, which are, with mental health or suicide, are the three things that are killing firefighters more than anything else. So if you have questions, concerns about any of those three things, that's a great local resource, or statewide in Minnesota. So my number is up top. If you need anything at all, if you need have a question, please feel free to give me an email, call my cell phone, and let's talk. And together we're going to do something about suicide. Thank you in advance for your help. Carpe diem.